All right, everybody, we're going to go and get started. Thanks for joining us today for Grand Rounds. I know everybody's super busy on service. The search status res times 1,000. So thank you for spending your lunch hour here with us. Today I have the pleasure of introducing one of our colleagues from the Department of Psychiatry. I think you all have worked with her at some point. She's ubiquitous. I'm introducing Dr. Carrie Ernst to us today. She's come to speak with us a few times, but not in a while. But today, she is doing us the service of giving us a lecture on psychiatric emergencies, which I think are something that we definitely see quite a bit of. So thank you, Dr. Ernst, for joining us today.
Thank you guys for having me. I always love coming and chatting with you guys. And every time we come, we always talk about how we need to start something regular between our consult service and the hospital, some kind of regular round. So we should, but then we don't follow up, but we should really try and make it happen because it's always great to share cases and talk together. So I'm going to talk about some of the psychotropic medication toxicity syndromes that we all encounter on the medical services, and we'll talk about catatonia. I'm not going to talk about agitation. I realize psych emergencies, you think about like suicidality and agitation, and about those, and that's sort of a whole separate topic. We're talking about psychiatric medical emergencies today. So I'm going to particularly highlight the three major life-threatening syndromes that we encounter in the med psych setting: serotonin syndrome, neuroleptic, malignant syndrome, and catatonia, because these are things we've certainly seen on our medicine services in recent times and on a semi-regular basis, especially catatonia. We'll talk a little bit about the differences between serotonin syndrome and NMS and talk just a little bit about some of the management. And then we'll finish by just reviewing some of the toxidromes that you encounter a lot: opioid toxicity, anticholinergic toxicity, sedative hypnotic toxicity, and just review some differences. How do you distinguish between them if you're encountering a patient and you don't know what that patient is toxic on? So I want to start with the case, and we could hopefully have time to get back to the case in the end, but a typical case, and feel free to tell me what you think now too, a 55-year-old male with alcohol and opioid use disorder, cirrhosis, diabetes, who was admitted for foot cellulitis and a status post-surgical debridement. Perhaps you're on the med consult service consulting to vascular, as I know you do. Patient has a history of major depressive disorder, is on fluoxetine 40 milligrams daily. You call us, the patient is very agitated and having visual hallucinations on post-op day 3. The current meds, the patient is still on the fluoxetine. The patient is also on trazodone, is getting PRN Haldol, is on linezolid, is on fentanyl, and on pantoprazole. And you see the patient's received 20 milligrams of IV Haldol, haloperidol in the past 36 hours for agitation. The patient's in 2-point restraints to prevent pulling at lines. And on exam, the patient is very inattentive and confused, oriented to self only, having visual hallucinations of animals, moderately increased tone in the bilateral upper extremities, bilateral clonus. The vitals, the temperature is elevated, it's 39, heart rate of 120, BP 165 over 110, and the labs are notable for a white count of 15,000 and a CPK of 900. So what are you sort of beginning to think about what might be going on with a patient like this? A med interaction, okay. So what kind of med interaction? Okay, so good. So the fluoxetine and the linezolid might be causing what kind of syndrome? Right, so serotonin syndrome. So linezolid, we'll talk a little later, is a weak monoamine oxidase inhibitor. So it inhibits the enzyme monoamine oxidase, which is important for breaking down catecholamines, things like serotonin. So, when used with an SSRI or any other serotonergic drug can cause serotonin syndrome. So maybe he has serotonin syndrome. That's possible. He also was on another serotonergic med on this list. Which one? Trazodone, right? And there's another one that's serotonergic that we don't think about, but is serotonergic and can cause serotonin syndrome when combined with SSRIs. Fentanyl also. So he's on 4 serotonergic drugs. So that could potentially be an issue. He also has cellulitis cirrhosis, so probably doesn't metabolize his serotonergic drugs very well. Okay, what else might be going on since we're talking about med toxicity? Right, so he's gotten a ton of Haldol, 20 milligrams. That's a pretty decent dose in 36 hours, especially for someone naive to it. And he has increased tone. He has a CPK that's elevated. He's delirious. He has a fever, right? Fever could go for serotonin syndrome or NMS, so he could definitely have NMS. Anything else that he could have? right? Alcohol withdrawal. I think that's a very common thing when we get called for delirium in a lot of these surgical patients. They're in alcohol or benzo withdrawal because it just wasn't known that they were using these things before the surgery. Post-op day 3 is sort of a little far for alcohol withdrawal, could be, or a benzo withdrawal. Right, so these are all very good thoughts. This is exactly what we would be thinking with a case like this. And sometimes it's hard to know, but hopefully I'll go through the rest of the talk and we can sort of think about what we think was the most likely possibility when we go back to the case at the end. So serotonin syndrome. So it's an adverse drug reaction that happens to be life-threatening, and it's not idiopathic. It's predictable. If you give someone too much serotonin, they will likely get serotonin syndrome. So someone who overdoses on a serotonergic drug or a combination of serotonergic drug will likely get some variant of serotonin syndrome. You can also get it from therapeutic drug use, especially if you're on multiple serotonergic agents together, or there's a drug interaction situation. A lot of the SSRIs are metabolized by a number of the P450 enzymes like 3A4 or 2D6. So if they're on metabolic inhibitors that raise the levels of the serotonergic dose, you can get it. And research shows about 14 to 16% of people who overdose on SSRIs come in with a presentation of serotonin syndrome. You can see a huge spectrum of findings. Probably a number of our outpatients have mild variants of this when they come in complaining of some side effects of very high doses of SSRIs. And you can have a spectrum of intensity of symptoms, which we'll talk about. The onset tends to be pretty rapid, which is interesting and a little bit hard to explain. When you read in the literature, it will say really within minutes. It's hard to understand how things would really get absorbed and metabolized into the target that quickly, but it is thought to be a pretty rapid onset. And most cases resolve very quickly. If you stop the offending agent within 24 hours, people usually begin to get better, except if it's a drug with a very long half-life, like fluoxetine. Prozac has a very, very long half-life. It also has an active metabolite, so it can really hang around for up to 4 weeks or so. Or if there's a protracted duration of action, like someone can't metabolize drugs well, their liver is not functioning well, you might expect to see a more protracted duration of the serotonin syndrome. As I mentioned, there's a spectrum of findings. So people talk about a triad of mental status change. So people are often delirious, they're confused. Autonomic hyperactivity. So they often have elevated heart rate and blood pressure. They usually are hyperthermic and elevated temperature, and neuromuscular abnormality. So you can see tremor, but you also can see clonus on exam, on the muscle exam. And that's sort of one of the most specific findings for serotonin syndrome. It's almost like a ratchety movement. Sometimes people can have spontaneous, where you look at them and they're sort of doing that with their arm, and sometimes it's more inducible, when you sort of examine them. And that's clonus. That's very, very specific for serotonin syndrome. You also can have, this is a famous picture from an article in the New England Journal of Medicine. It's a great review. It's old at this point, but a really great review of serotonin syndrome. People are very diaphoretic. They have a lot of diarrhea, flushing, hyperreflexia. Mentioned, these are really extremes of the side effects people get with SSRIs. Often people who take SSRIs, when they start, they'll tell you, I'm having diarrhea or some flushing or a little bit of a tremor. It's probably just mild serotonin toxicity. So obviously these patients are usually much, much sicker, but there can be a spectrum, and people can have a mild presentation of serotonin syndrome. In addition to the things I mentioned, you can have abnormal lab findings, but they're usually very non-specific. Some people can have signs of rhabdo. Some people can have renal failure or metabolic acidosis. You could see people with seizures. You could see DIC, but none of these are specific lab findings for serotonin syndrome. And many of them may be less the serotonin syndrome itself as much as having clonus or rigidity or lying in bed for prolonged periods of time and sort of sequelae that happen there. Their pupils tend to be big too. They have increased bowel sounds. They're very hyperreflexic. There are a lot of drugs that can cause it. I think it's obvious when you think about the SSRIs, sort of the antidepressants in psychiatry, trazodone as well. People mention the older antidepressants too, like a number of the older tricyclic antidepressants, things like amitriptyline, some of the monoamine oxidase inhibitors, which you don't see people coming in on that often anymore, but sometimes people still do. But other things like that are regularly used not by psychiatrists are things like some of the analgesics. Tramadol has a lot of serotonergic properties. That's frequently used. Fentanyl. The antiemetics, although there's a lot of debate and it's not totally clear that the antiemetics or the anti-migraines, the triptans, are such a concern for serotonin syndrome just because of the particular subtype of the serotonin receptor they're thought to affect. But in theory, with combinations of multiple serotonergic drugs, they can contribute to serotonin syndrome. We talked about linezolid. Dextromethorphan is another one, especially for outpatients who are coming in taking a lot of that. If you overdose on dextromethorphan, you can get serotonin syndrome. Some of the other drugs of abuse like MDMA, ecstasy, LSD, they're very serotonergic drugs. And also we recently had a patient who came in with some serotonin toxicity symptoms, was being prescribed an SSRI, but also was taking St. John's wort. So we all know to always ask patients what they're buying over the counter. That is an MAOI as well. So that also causes serotonin syndrome. Lithium has some serotonergic properties too. So there are a lot of drugs to think about that can do this. There are a number of different sets of diagnostic criteria. I mean, this is a clinical diagnosis. As I mentioned, there's no one lab test that's going to make you diagnose it. But the first question, and it's almost sort of silly to have it there, but it is important because some of the consults we get. So has a serotonergic agent been administered in the past 5 weeks? Like, you'd be amazed, not from you guys, but how many consults we get from other services for serotonin syndrome when the patient has never been on a serotonergic drug, or for NMS when the patient has never been on a dopamine blocking drug. So obviously you have to have had one of those kind of drugs in the past 5 weeks. Just being on psych meds and being delirious doesn't mean it's one of these toxidromes unless they're on one of the meds. Yeah.
The time course in the 5 weeks.
Mm-hmm. I mean, usually, as I was mentioned, it's very early, like within minutes, but the reason they say in the past 5 weeks, because some of them, like fluoxetine, have very long half-lives. So like, let's say the patient was on it, but stopped it like 3 weeks ago, and they come in, it's not on their med list because their psychiatrist stopped it 3 weeks ago, but they could still have it, in their system. It's still hanging around. So that person, in theory, could still get serotonin syndrome if you gave them another serotonergic drug and, there was an interaction or they couldn't clear it somehow. So that's why it says that, just to account for drugs with long half-lives that are still around. So obviously you have to have been on that. And then, any of the following symptoms present, and the most important is this clonus, but, you can look for the other very important symptoms. They're all the ones we talked about: tremor and hyperreflexia, rigidity, high fever, again, inducible clonus, or you can get clonus in your eyes too, apparently, although I don't know that I would know what that looks like. I don't know that I've ever seen that. Ocular clonus and either agitation or diaphoresis, various combinations of symptoms. So you'd be looking for these symptoms. There's other criteria that's a little bit simpler that just says, like, was there a recent addition or increase in a known serotonergic agent? You've ruled out other causes. They sort of say no recent addition or increase of a neuroleptic, I think, to rule out that this is NMS, and and then more than three or more of the symptoms that we talked about. So there's not like one universally accepted set of diagnostic criteria, clinical diagnosis, but these are basically very similar. You need some constellation of these symptoms. And how do you manage it? Really, the management is supportive. You stop the drug, and most people get better quickly. If people are agitated, usually we use benzodiazepines for the agitation. We try to avoid restraints because things like restraints can then lead to increased muscle breakdown and rhabdo, or can cause other trouble. You're mostly managing the autonomic instability if they're very tachycardic or hypertensive. Usually, if the fever is very, very high, if they're hyperthermic, the guidelines say sort of above 41.1, that patient probably should be intubated in the ICU, sedated, paralyzed. Hopefully we haven't seen too many patients that bad, but those are the very sick patients. There's a question about whether you use these serotonergic antagonists, 5-HT2A antagonists, especially Cyproheptadine, or some people even suggest thinking about some of the atypical antipsychotics to manage it. But really, I think I can count on one hand the number of cases I've seen since being at Sinai for the last 11 years where they've actually used Cyproheptadine. Those have only been the cases with the very, very high fevers and autonomic instability that have gone to the unit, and have sort of not been getting better. And they usually try, as a last-ditch effort, they try Cyproheptadine. And, this is sort of the dosing recommendations. There's sort of maintenance dosing. It can only be given orally, which is sort of a problem for critically ill patients. But if there's an NG tube, it can go in there. But it's not generally something we would do on the floors unless someone really had a lot of autonomic instability and was not getting better. Most people do get better. Does anyone want to ask any questions about serotonin syndrome before we talk about NMS? Okay, so NMS is the other big one, right? So this is much less common since people are mostly using atypical antipsychotics these days. The incidence rates are much lower than they've ever been, 0.01% to 0.02%, so lower. As opposed to serotonin syndrome, which is sort of a predictable consequence of excess serotonin, NMS is thought to be idiosyncratic. Like, we don't really know who's going to get it. We can't really predict it. It is life-threatening. It's a complication of dopamine blocking drugs, which are mostly the antipsychotics, but I'll mention there are other dopamine antagonists that other physicians use, non-psychiatrists, that can cause this too. Mortality rates are about 10%. And the four main symptoms are fever, so that's similar to serotonin syndrome. Rigidity, usually they have more rigidity than the serotonin syndrome patients. It's called like a lead pipe rigidity, a lot of increased tone on exam, not the clonus, just increased tone, very, very heavy limbs. Autonomic instability again, and mental status changes. So similar, but different cause. And the history, it was really described in the 60s of this syndrome, of these symptoms after neuroleptic exposure. In the DSM, that's the guide we use in psychiatry to provide diagnostic criteria. It was mentioned in the 90s, in 1994, and the diagnostic criteria were sort of this severe rigidity and elevated temperature associated with neuroleptics, and then they had a whole list of other symptoms that you needed. Characteristic features. Interestingly, in the most recent edition, they don't give any specific criteria for NMS anymore. I don't know why they did that, but there are, just like with serotonin syndrome, there are various sets of diagnostic criteria you can look at. It's still a clinical diagnosis. And, because drugs can present, especially atypical antipsychotics can present with atypical NMS, you just want to have a very low threshold to be thinking about it. And you probably don't need to meet all of these criteria. But this is, one group's an international criteria where they said you need to have exposure to a dopamine agonist in the past 72 hours, or antagonist, or dopamine agonist withdrawal. So that's another interesting point. Like if someone's on something like Sinemet, a dopamine agonist, and it's been stopped suddenly, they can get NMS too. It's not just caused by D2 blocking agents. And the features, so hyperthermia, the BP elevation and fluctuation, the heart rate elevation, usually in the labs, you can see a lot of non-specific things, but the CPK, as you all know, is usually elevated, at least 4 times normal. In the severe cases, most patients have thousands to tens of thousands in the CPK, not the sort of like 400 or 500 that we see when our patients have been lying in bed for a long time, but very, very high. Obviously, you want to exclude other reasons why the patient might be hyperthermic. Usually, if you were to get CSF findings or image their brains, usually you don't see anything of note there. If you do an EEG, often you'll see generalized slowing the same way you would for most other delirium kind of situations. Sometimes you can see a white count increase again, which is complicated because white count and fever can be a lot of different things. So, of course, we don't want to sort of assume it's the dopamine blocking agent without ruling out other causes, but often you do see that. So antipsychotics are the most common cause, but don't forget the dopamine antagonist drugs, the antiemetics, so metoclopramide, which seems to be used often, prochlorperazine, promethazine. We don't use here droperidol very often. Some hospitals use a lot of droperidol for nausea and vomiting, especially in their ER, which is sort of similar in structure to haloperidol. So those can be. And then abrupt withdrawal of dopamine agonists. Apparently, there are also reports of abrupt withdrawal of baclofen causing NMS, which is interesting. There's a lot of effort to look at who is at risk. We don't totally know. Probably people that have central nervous system dopamine dysfunction to start with, like probably Parkinson's type patients or maybe HIV patients are probably more at risk. People who have had prior episodes are more at risk. People who have been restrained and gotten very high doses of high potency dopamine blocking agents are at risk. So this person who's been in restraints, our case, getting 20 milligrams of a high potency dopamine blocker in a short period of time is at very high risk. It's thought that people who got a lot of IM or IV antipsychotic are a high risk. People who were titrated faster and given higher doses, these are the people who are at risk. Dehydrated patients are thought to be more at risk. With a lot of patients, And this is what complicates it. The mental status change precedes the systemic signs. So they might look delirious before they have stiffness or before they have elevated blood pressure or fever. So sort of we're always taught in psychiatry, if you have a patient who comes in with delirium and they're on an antipsychotic, NMS needs to be in your differential no matter what else is going on, even if you don't see the other stuff yet. And as opposed to serotonin syndrome, which is usually pretty fast onset, quick, this is more insidious. Usually it's over a couple of days. You can see hours, like if someone were in the ER or on the medicine floor and got high doses of antipsychotics in a short time, they can get it quickly, but usually most people present within a week of having all this dopamine blockade, 66%, 16% within the first 24 hours, but most people are a little later. Almost everyone within 30 days. There are reports of later onset, especially if someone just had a dose increase or a new med added that interacted, but it's not that common. If someone's been on the same dose of an antipsychotic for years and years, and all of a sudden they're coming in with delirium, it's a little bit unusual that would be NMS after all those years. You can always think about it, but it's less likely. Usually once you stop the medicine, it's self-limited, and most people get better. It takes about 7 to 10 days, so it's usually a longer recovery course than serotonin syndrome. If anyone was on one of those depot antipsychotics, so the shots, the once monthly shots or every 2 weeks, of course the course is going to be prolonged because you can't reverse the shot, unfortunately. I don't want to spend a lot of time talking about pathophysiology, but it's thought that individual people are vulnerable. There's been research on things like the genetics of the dopamine transporter or the dopamine receptor, trying to understand who's at risk. Likely there are a number of different things that happen that lead to dysregulation of the neuroendocrine system, and that causes some kind of hypermetabolic syndrome. And somehow things are triggered by lowering the dopamine tone in the central nervous system. And, obviously dopamine plays a role because this relates to dopaminergic drugs, but there's also interest in the involvement of other neurotransmitters as well. This is just, if you're interested, there's a good review article in the American Journal of Psychiatry from 2007. This is a very complicated model, but just sort of showing that, you give your dopamine blocking drug and it can cause a lot of problems in a lot of different systems. So the symptoms we see are probably related to dopamine blockade in different parts of the brain in particular. So blockade in the nigrostriatal pathway leads to these sort of extrapyramidal motor symptoms, whereas you might get fever from blockade in the hypothalamus and that sort of thing. So it's really, these are syndromes. The differential diagnosis, of course, is all of the usual things you think about for fever and white count and stiffness. Obviously, infectious kind of causes are big on the list, but other things like serotonin syndrome or other sort of toxidromes are important to think about. Withdrawal from different drugs, other brain causes like structural brain lesions, things like pheochromocytoma. There are other things, heat stroke, there are other things that can look similar as well. For management, similar to serotonin syndrome, we stop the offending drug, and most of the treatment is really supportive, just supporting volume and vitals and fever, cooling measures, electrolyte abnormality correction. That's what you're mostly doing. There is not a big consensus about whether to use medications to treat it. There's a little bit of data that if you give benzos, it can help with agitation. In this setting, like obviously you wouldn't want to use an antipsychotic for agitation, so benzos can be helpful. There's some literature on dopamine agonist drugs using the rationale, like this started from a D2 blocker, so what about using something like bromocriptine and amantadine? And there is some data that they might improve mortality rates and reduce time to recovery if you start one. So, but I have not seen them used again unless people are in the ICU and really very ill. Sometimes we use dantrolene, usually in the ICU setting. I don't even think it can be done on the floor here, but usually if there are extreme temperature elevations and rigidity, they'll try to use dantrolene. For refractory symptoms, if people are not getting better, ECT is generally used too. And sometimes they need up to 10 treatments for that if the symptoms are just not resolving. And the reason for that, as I'll talk about, is people think of catatonia and NMS as on a spectrum together. So some of these patients may, have features resembling catatonia, and ECT is a treatment, important treatment for catatonia, so it's used for NMS.
And on average, how long do you expect for something to resolve?
Usually within a week, within 6 to 10 days or so, it will resolve unless someone's on a decanoate. But sometimes they become catatonic from this, and then they won't resolve unless you've given them a lot of benzos or gone to ECT. but it does take a little bit longer usually to resolve than serotonin syndrome does. And these patients seem to be sicker, the ones we've seen. One thing to know, though, is atypical antipsychotics seem to cause atypical NMS. So I always tell the case that was most striking to me I had when I was a fellow, there was a patient on Clozaril with schizophrenia, and he came in with renal failure, and his CPK was very high. It was like 30,000. He had rhabdo. But he otherwise looked very well. He didn't look sick. He didn't look toxic. He didn't have fever. He didn't have delirium. And everyone was like, well, it must be the Clozaril. So we held the Clozaril in the hospital, and the CPK came down, steadily came down every day. And we rechallenged him, and it went back up again to 30 or 40,000. So it was an interesting case. He obviously had atypical NMS. You would never have known except for monitoring lab values, but you can see that. So they're seeing less rigidity, less tremor, less fever, smaller CPK increases, much milder courses. So especially with drugs like clozapine, aripiprazole, we don't have amisulpride in the US, but the drugs that are not such potent dopamine blockers. So that's something to keep in mind that you can see. I don't think no antipsychotics are free of risk, but these patients often have much better outcomes, less likely to have mortality rates or high clinical severity from the atypicals, but it's still NMS, so you still have to handle it as such. This particular patient was a dilemma because he needed the Clozaril, and we sort of didn't know what to do with that situation. But it's sort of a risk-benefit assessment, and I don't remember in the end, we might have tried a different antipsychotic, put him on something else like aripiprazole and that sort of thing. The question always comes up, can you rechallenge? Can you give them back the antipsychotic? I mean, potentially, probably not while they're still in the hospital, though, although it would be nice to monitor them. The guidelines say wait at least 2 weeks after the symptoms have resolved. There's about a 30% risk of repeat NMS if you rechallenge them. So usually we would be a psychiatrist of doing that, documenting the indication, documenting informed consent, trying maybe something that was an atypical or much lower potency drug, like if someone got NMS, our guy that I talked about at the beginning from Haldol, you probably would try something that was an atypical if you needed to, and you'd titrate very, very slowly in that situation. Any NMS sort of questions? Okay, so similar looking presentation to serotonin syndrome, but more like serotonin syndrome, more likely to have the clonus, NMS more likely to have this sort of lead pipe rigidity and the elevated CPK. Also more likely with serotonin syndrome to have things like diarrhea and flushing and diaphoresis, although of course anyone with fever could have those things, especially diaphoresis. So catatonia is the third of the big life-threatening things we see, and we've had a number of cases this year. We always do every year in the hospital with catatonia. And so catatonia is a syndrome. It's not like one disease. It can be associated with a lot of different psychiatric disorders. It can also be due to a medical condition. It's a constellation of symptoms that people can get. And there's a whole list. So this is like in the DSM-5, there's a list of things. So DSM-5 says 3 or more of the following. So it's usually a combination of sort of mental status change related symptoms and motor symptoms. So the mental status symptoms, things like agitation, being mute, so saying very little, being very negativistic, so either opposing anything you ask them to do, so just like either refusing to do it or doing totally the opposite of what you ask them to do. Echolalia, meaning they repeat what you say. So, hello, how are you? Hello, how are you? They just literally repeat it, or echopraxia, they mimic your movement. So we had a patient recently. So I was in there with the resident, and the resident was sort of gesturing, talking to the patient, and the patient was doing that. Not sort of in a purposeful way, but just imitating. So that's a typical catatonic kind of symptom. A lot of the motor symptoms are a lot of bizarre posturing. So they could sort of vogue. They might sort of stand in the middle of the room or in the middle of the hallway like this. Have you guys ever seen anyone doing abnormal movements in catatonia? What were they doing? What? You do, I mean, you can see posturing in just delirium or other kind of things, but often there's some, like we had one a couple months ago that was just sitting in bed like this. I mean, or you'd move the hands and they just wouldn't, the patient just would sit there for the whole interview with the hands suspended in midair. So that's the kind of thing you can see. They can be very, very agitated, running down the hall, pulling out lines, but they can also be the opposite, like stuporous, not talking, not moving, not eating, not doing anything. They often, if you sort of move their hand, they'll often hold it in that position. So if you sort of take their arm and put the arm up, the patient will not put the arm down. We'll just sort of hold it in the position you've left it in. So that's one of the typical things you can see. So it's an interesting syndrome. Often I would say that if patients look sort of delirious to you, but there's some bizarre component, like some bizarre motor symptoms or mimicking behavior or something like that, you should be thinking, are they catatonic?
When someone's catatonic and you try to move their posture, will they fight?
Sometimes they will. Sometimes they will. That's one thing. They might fight, or they might just leave it, like bend with this waxy felt. It's a bit like you're bending them like a candle. Like if you think of a soft wax candle, they might just bend and sort of just not be resisting you. But they can resist. That could be a different symptom where they just resist. We don't know. I mean, pathophysiology is not well understood. Obviously, like the motor pathways are involved, as well as the pathways that, deal with autonomic function and, the limbic pathways. When people come out of catatonia, often they will remember, as opposed to delirium. Often, like when people are done being delirious, they might remember little bits and pieces, but they usually can't relay to you conversations. Often when the catatonia resolves, they'll say, yeah, I remember, we had a patient a couple months ago, I remember you all standing over my bed and trying to talk to me, and I just couldn't respond. I just couldn't. Sometimes they'll say they'll look very fearful, or say I was too anxious, or I was too scared to respond. This patient we had a couple months ago seemed to be, but just had this petrified look in his face, but he remembered every single thing that had happened. I remember moving my arms, remembered everything in the room. So often they remember. So it's an interesting sort of state that can happen in very, very severe cases of psychiatric illness, but also medical conditions. So in psych inpatient units, people will say the prevalence is very high, up to 10%. I'm sure that depends on what inpatient unit we look at. Like if you're looking at the old state hospital units, that's probably true. I doubt it's true on our Madison 5 units. What you worry about with catatonia is it can progress to a malignant form where there's autonomic instability. It starts looking a lot like NMS after a while, and a lot of people think NMS is actually just catatonia, but due to dopamine blocking drugs, because they look so similar. So you worry that they can become delirious, they can become autonomically unstable, they can go into coma or death, and that's called malignant catatonia. Not everyone goes that route, but that's one of the things you worry about. So the most common psych disorder associated with it is bipolar disorder. So if they have a bipolar disorder history, that sort of supports your case a little bit. But you can certainly see it with schizophrenia, major depression. You can see it with developmental disorders or autism. You can see it with, really alcohol or benzo withdrawal, anything really. But the mood disorders and schizophrenia are probably the most common. But it's important to know that depending on what source you look at, probably 20 to 40% of cases are not due to a psychiatric disorder. They're due to a general medical condition. So that's always the dilemma, I think, when we get called and you see these patients too, is to figure out, is it a psychiatric cause? If so, we need to sort of address the psych treatment, or is there some medical condition causing catatonia? There are a lot of drugs that have been implicated besides the neuroleptics that we talked about, a lot of medical meds type drugs, some of the opioids like morphine, anticonvulsants, steroids, stimulants, hallucinogens, metoclopramide, alcohol or sedative hypnotic withdrawal. These are things that can be implicated. People wonder, how do you distinguish from NMS? Because they look so similar, especially if people with schizophrenia get catatonia. How do you know if it's their antipsychotics causing NMS or their schizophrenia causing catatonia? I mean, as I mentioned, they're thought really to be very related, but in NMS, you're really more seeing the autonomic instability, the fever, the rigors, the diaphoresis, the CPK elevation. In catatonia, most people, when you look at data, are more negativistic, not speaking, having the bizarre movements, the posturing that I mentioned, the stereotypical behaviors. So that is one way to try to distinguish, but management is similar. So I personally don't worry as much about distinguishing them, because you would not want to continue dopamine blocking drugs in catatonia either, because they can make it worse. I don't need to tell you the medical complications associated with catatonia. You've all seen these patients who, if you're stuporous and you're not eating and you're not speaking and you're not moving, they can get all these things. They can become dehydrated, get PEs, DVTs, aspiration. In malignant catatonia, obviously, when you have uncontrolled autonomic instability, any number of bad things can happen as well. So the workup is really trying to identify the medical cause. An EEG can actually be helpful. Often, if it's totally normal, which is impressive to see a normal EEG with people looking this bad, that's much more consistent with a psychiatric disorder. An abnormal EEG, like slowing, would be more consistent with any number of sort of non-psychiatric causes. Imaging can be helpful to see if there's a big tumor. CPK levels can be helpful. Often we'll do a diagnostic test to see if it's catatonia. So you give Ativan at the bedside. You could do this, give 1 or 2 milligrams IV. And if it's going to work, it's pretty amazing. Within minutes, probably within 5 minutes, somebody will just start talking and sort of say, oh, I remember you talking to me. It's just sort of, I always, in psychiatry, there are so few things in psychiatry that work that quickly. It's sort of one of the more rewarding things in psychiatry to actually see an immediate response. So obviously, if it works, then you'd start scheduling it. If you don't want to give benzos, there's people will use zolpidem. Obviously, none of these things are like FDA approved, but the benzos are very well studied for catatonia and are accepted as the standard of care for catatonia. But you can use zolpidem if for whatever reason you're worried about respiratory compromise and you don't want to do it. We support them with supportive treatment, whatever they need, whether it's tube feeds, NG tube, IV fluids. If a dopamine agonist has been recently stopped, like the Cinemat just happened to have been stopped, we try to restart it. Usually we stop antipsychotics, any dopamine blocking drugs. It becomes a problem, though, because if you have someone with schizophrenia, you're stopping their antipsychotic, like, what do you do? So often, like, once the catatonia resolves, once you get them out of catatonia, we might cautiously restart those psych meds. But while someone is catatonic, we usually don't give them antipsychotics. And benzos are really the first-line treatment. Most commonly, people use lorazepam, just because it's easy to give IV, but certainly any of the others you could use if you wanted. And usually you try 1 or 2 milligrams, and you could titrate it up to, there are literature reports of up to 24 milligrams a day. That seems very high. We haven't had a patient on that high. But, if it's beginning to work, you might need to schedule it pretty frequently to keep, because often it will work, and then they'll slip back into catatonia again. And so you have to give it multiple times a day. There's no consensus on when to stop them. So we're always sort of at this place of like, okay, we've got them out of catatonia with benzos. When do we take them off the lorazepam? And nobody really knows the answer to that question. We have a couple of patients who stay on them long term because they seem to sort of lapse back into catatonia when they come off. Most people, like, you've lysed the catatonia and you could begin to taper them off once they've once they've been well for like 24 to 48 hours, you could begin to taper off. Some people use zolpidem, as I mentioned, and there are case reports with all sorts of other things like memantine, bromocriptine. You can find case reports, but those are not sort of the standard of what we do. But if they don't respond to benzos, usually ECT is sort of what we think about, because this is life-threatening. Usually we'll give them up to 5 days of a benzo trial, and then because it sort of takes that long often to prepare for ECT anyway. But, ECT is going to give you a rapid response. Often you don't have the luxury to wait if someone's refusing to eat, and, especially if they have autonomic instability. If they have an underlying psychiatric cause that warrants ECT anyway, you might go faster. Like they have a severe, a depressive episode, ECT would be appropriate. It's been studied probably more in the case. There are hundreds of case reports and a number of small studies with ECT, and the response rate seems to be fairly high. Some studies show like 40%, some 60, 80% response rate. So very high response rates with ECT, often just in a couple of sessions. Sometimes people need a few more sessions to prevent relapse, but it's sort of the fastest ECT response we see too, just 2 or 3 sessions and you've lysed the catatonia. And if you treat people well, early and aggressively, they can do well. I would say it also depends on the underlying diagnosis. We've had in the last few years a couple of catatonia cases on the medicine service of just elderly patients with severe dementia who come in sort of a catatonic place. And we had tried ECT for 2 of them, and they didn't do well. I think one eventually died, and the other one just didn't come out of it. I think if the underlying condition is something that's not going to get better, even ECT will only have of limited benefit. But most people do respond to benzos. So I think the important thing is that we talk about a continuum, that a lot of people talk about NMS and malignant catatonia is really on the same, they're all sort of on the same spectrum. People even talk about mania because catatonia is so common in bipolar disorder of mania even being on that spectrum too, like a spectrum of severity of how bad things are. So this is just the place to sort of wrap up. This is like a very busy table, and if you want, I can send it to you. It's more like, I think, a pocket kind of table, but just to sort of be thinking about all of the different toxidromes we can potentially see. I mean, we did the one at the top, serotonin syndrome and NMS, but a lot of these patients where you'll be thinking about serotonin syndrome or NMS are also the kind of patients who might be using opioids or sedative hypnotics like benzos or alcohol, anticholinergics. On the psych boards, they love to ask this question about a patient. They ask usually about someone who is on like an one of the older antipsychotics, cholinergic as well, and they'll present a toxidrome, and they want you to tell them if it's anticholinergic toxicity or NMS, right? It's hard because it's the same drug, right? The same drug is both a dopamine blocker and anticholinergic. So, and sympathomimetics, so people who have used amphetamines and cocaine. So these are it's always sort of interesting unless you have a drug screen or a pill bottle to know what the patient might have. So, just a couple of points to make. Opioids, the pinpoint pupils is, you see that a lot with opioid overdose and respiratory failure, decreased or absent bowel sounds. So, that might, as opposed to sedative hypnotic, like a benzodiazepine overdose, the pupils are usually normal. Both of those patients can be lethargic or stuporous or in a coma, but the pupils can help you differentiate in those. The syndromes where people would be very agitated and not stuporous, like anticholinergic toxicity, the sympathomimetic toxicity, those patients, you can tell a little bit by the skin. So anticholinergic toxicity, people are very dry. Their mucous membranes are very dry. Sympathomimetic, like an amphetamine overdose, cocaine, often they're very diaphoretic. It's sort of the opposite. Pupils are big with both. The bowel sounds are different. Anticholinergic, they have decreased or absent bowel sounds. Often with sympathomimetic, you have diarrhea and increased bowel sounds. So, it can be hard to tell sometimes, and you hope that people can kind of wake up enough to tell you what they actually took. And often, unfortunately, it's a mixture of things because people don't usually just take one drug to overdose. They take multiple drugs, and you're seeing elements of different ones. But, I think it is sort of, useful. I always find it useful to sort of refer to a table when we're getting called for some kind of med toxicity and to sort of be thinking about which one is it and to try and sort of work through a little bit of the differential. This is one I got from the internet. I love the website. They call it, it's 67em.com, Altered Mental Status for Dummies, Part 2 approach. Not that any of us are dummies, but I couldn't resist because I found this and I loved it. I thought it was much better than my table. Right? You can find it, you can go to it yourself, and it's a very cute way of depicting all of these. What? I like their pictures. Right, the bell sounds, the mute. Right.
This is really good.
It's a good one. I'm happy to send you guys those slides. You can all have it, or you can go to that website yourself. All right, so let's just finish up going back to our case. So now that we sort of talked about all these things, do you have a thought about what's the most likely diagnosis in this guy? Okay, yeah, why? Right. Yeah. I would agree. I think serotonin syndrome is probably most likely. It's hard to know 100% for sure, but the clonus, as I mentioned, is very specific. The diarrhea is more common in serotonin syndrome. The CPK is not that impressive, although it could be on the way up, though. Remember, it's very early. So, you're just talking about in the past 36 hours. You'd want to keep checking it to see. And, it's hard. This is probably a patient you'd stop all these psychotropics, unless you really, I would probably stop them and give benzos in a patient like this for agitation just to be on the safe side because you don't know. But I think just the lab values and the exam are probably more consistent with serotonin syndrome. Okay, that's all I had. I'm happy to take questions or hear about cases. Yeah.
I'm thinking back to that case that you described, the closet world. These cases where it's not necessarily dose dependent and even the small doses cause hypothermia, do you label those as now drug allergies so people know going forward, or how do we kind of import this into the medical record?
I think that's a great question, because I don't think it's an allergy exactly. It's an adverse event from a drug, which is different than allergic reaction. I mean, does the record allow you to document adverse events separately from allergy?
Can it also myocarditis? We have one patient
Yes.
that was transferred to us from Keystone, and the patient
Is this the one that was on Madison 5 for so long? Oh.
was transferred to Mindwest.
Oh.
Was intubated, and it says the patient has developed myocarditis from Clozaril.
Yes, you can, which you can usually in the first 4 to 8 weeks of treatment. It's very rare, but certainly possible people can get myocarditis from Clozaril. It's a well-documented potential side effect. I didn't know if there was a patient we were following for a long time who was started on Clozaril on Madison 5 and developed cardiac failure. I don't think they ever quite figured out why. They didn't think it was myocarditis. That's why I was wondering if it was the same patient, but
I mean, so
What?
it just kind of like is an interesting question.
Yeah.
How we then impart that knowledge on to these atypical reactions.
right, because you also don't want to communicate that you could never re-challenge, right? Because sometimes when you put them in the record, then, oh, okay, it's an allergy, I can never get it again. But that's not necessarily the case, right? You might titrate much more slowly or get by at a lower dose. So, yes, I don't know like the details of our record. You'd hope if there was an adverse drug reaction section, you could say, developed atypical NMS from Clozaril, and let the future providers decide whether to re-challenge. What in the district? I mean, you also hope it's accurate, though, right? Because sometimes there's a lot of assumption, oh, this is NMS, and then, when you sort of look through the whole thing, you're like, yeah, I don't really think this was NMS. I actually think it was something else, and then, someone's med that they need has been stopped, and it's sort of unfortunate. But it is better to be conservative in these cases, right? If it's in your mind that it's possibly going on, you probably should hold the medicine. I mean, if you hold it and they get automatically better, you sort of have your answer. That is the good thing. Usually people get better quickly. If they don't get better, it probably wasn't the drug. All right, well, thank you guys for having me.